to you one day.
Perfect. Thank you. Yeah. Whenever you're ready. Okay. So it sounds like more people are going to be jumping on, so we can go ahead and just record this first bit. And then we can kind of move on from there then. So let me share my screen. Give me just 1 second. So I think we've stalled enough. Okay. Now. Screen. Okay, can everybody see the screen right now?
It's not gone to share screen yet. There you go. It's pacing modes and codes.
Perfect. Okay. Fantastic. Okay, so I'll go ahead and jump in. If people need let in, please let me know, because I can't really see that using my tiny screen right now and my presentation. So we'll be happy to add them as they come though. All right, pacing modes and codes. So if you remember where we left off, we spoke about bradycardia, the indications for pacers, and then we're just going to move on to the NBG codes. So the NBG codes is just a way to kind of classify the mode that a current pacemaker is set to. So the limiting factors, let me let this person in. The limiting factors for what code you select is the hardware itself. So is this a single chamber device? And then also things to keep in mind is, are there issues with existing leads? So we can program a dual chamber device to act like a single chamber device. We cannot program a single chamber device to act like a dual. I know that makes sense, but I felt like I should cover it. So the way that what these things represent, VVI, DDD, all these things that we'll go through later, is based on their position. So when you look at chamber 1, for example, if you see a V in chamber 1, that means it paces in the ventricle. So anything, the chamber that it paces in will be the first position. Second position will be the chamber that it senses in. Third position will be its response to that sensing. And then the fourth position is just rate modulation. That's whether or not a sensor-driven rate for chronotropically incompetent patients is turned on. And I'll cover that later. And there's plenty of examples for this if you didn't quite catch all that. So in this case, let's move along. The most simple one you'll probably ever come across is a VOO device. So what that means, if you remember up here, it paces in the ventricle only. It senses in the ventricle none of the time, and it doesn't respond to any kind of sensing because there's nothing to respond to. So basically what that means is that the device is completely blind and it just paces at a steady rate. So when we talk about like a base rate of 60 beats a minute, remember that pacemakers do not think in BPM like a human mind does. They think about it in milliseconds. A pacemaker is just a bunch of little clocks that all kind of start and stop at different times. And we can go over that in later lectures, but essentially what you're saying is if a device is set VOO 60, for example, the device waits 1,000 milliseconds. And if you ever need to do the math for this, it's to figure out the milliseconds, it's 60,000 divided by BPM equals milliseconds. So in this case, 60 beats a minute is 60,000 divided by 60 equals 1,000 milliseconds. So in this case, programmed VOO 60 means it paces. In this case, you see it captured. It waits 1,000 milliseconds or the equivalent of 60 BPM, and it paces again. Now, right here is a little odd. Like, what are we seeing here? This is an EKG, and why are we not seeing an evoked response? Well, this is an intrinsic QRS complex, obviously. The device is set to not pay any kind of attention to anything that's happening and pace no matter what. So it paces. Unfortunately, it kind of paces into a T wave, which is not ideal because this can be pro-rhythmic, but it doesn't really know any better. It resets a timer, waits 1,000 milliseconds, and paces again. Now, in this case, you see a preceding P or atrial activity right here, followed by the depolarization. Here's a pace. It waits 1,000 milliseconds, paces again. Now, you see the morphology is a little different. This would be an idea, you may hear the term fusion. So what's happening here is we are pacing. At the same time, you have this intrinsic Atrial activity, it conducts down. If you remember last week, we were talking about the atria, and let's go ahead and draw. I got a pen and I got time to stretch it out. So you have your beautifully drawn heart here. You have your upper chambers. So your RA, I'm not going to bother writing anything else out because this is incredibly tenuous. You have your SA node, you have your AV node, and then you have your bundled His to your, ignore that this is outside the heart. So this is your standard conduction system of the heart, right? So you have your atrial activity occurs, it conducts to the AV node, it hits a slight delay, and then it moves its way down the normal conduction system to depolarize the ventricles, right? Well, in this case, we are pacing at the exact same time in the RV. So you have this intrinsic conduction causing depolarization and then pacing that fuses at the same time. So anytime you see anything like this right here, this is a fusion because you're having the intrinsic activity complement our pacing activity. You may hear a term called pseudo-fusion. That just looks like we might have fused, but the complex will look exactly the same. Does anyone have any questions on that? I can belabor this point or move along if anyone doesn't have any questions.
Please, you can belabor it, right?
I'm sorry?
You can go ahead and explain, please.
Okay.
The difference between the pseudo and the fusion.
Yeah, absolutely. So for those of us like Elvis who are taking the IBHRE, which is a very fun test, but this will be something that will come up. And basically you'll see this manifest itself in a pseudo-fusion where we'll have a pacing spike occur directly before a QRS, but the morphology of the QRS looks exactly like the intrinsic morphology. So there's no contribution of the pacing to the actual cardiac activity or to the EKG, to the electrical function of the heart. Versus a fusion, you have your pacing spike occur, and you have the contribution of the intrinsic conduction that will affect the way the entire electrical impulse travels throughout the heart. This will usually manifest itself as more narrow than a intrinsic or a typical pace or a PVC in this case as well. You see these wider complexes. So in general, when you see a true fusion, you have a hybrid look to it. So you'll end up being a more narrow, but maybe not as narrow as an intrinsic than the normal paced event. But that's just a contributing factor of the two kind of occurring at the same time. So I know this is kind of roundabout in a little segue here, but I got a little, distracted here. But in general, what we're seeing in VOO, and you'll see a lot of this weird stuff, and that is one inherent problem with VOO, right? Is the device doesn't know any better. It just paces 60 beats a minute, if that's how it's programmed, forever. Now, the reason you may ask yourself, why do we choose VOO then at all? There could be a number of factors. If the patient's going in for surgery, electrocautery can cause a device to withhold pacing. So if you have a dependent patient who is going in for a shoulder surgery, for example, that electrocautery could confuse the device that this intrinsic noise here is actually a QRS complex, which will reset a timer on a pacer. It will wait and withhold a pace. So if this cautery is still going on, you could have a 10-second pause, which is generally not ideal for most people. So in those cases, we'll program the device VOO or asynchronous. So no matter what, it will pace, it will not sense, and it will not respond to any sensing. Finally, we don't have rate modulation on. We'll talk about that later. But this is your most basic sense. And the only time you'll ever see it, clinically outside of a surgical setting would be if a patient has issues with their lead, where we're worried that oversensing due to noise or anything like that could cause the device to inhibit. So dependent patients with noise issues on the ventricular lead, you may set them VOO as a bridge to a lead revision. And it's just a way to make sure that we're not inhibiting when they're in the field, causing any kind of syncope or dangerous events to occur. Everything makes sense there? Pretty straightforward.
Yes.
Cool.
Yes, it does. But I have a question. Can I
Yes, sir.
ask? All right. So, regards the lower rates, perhaps for surgery, you change to VOO. If it's a double chamber device, right? Or if it's a single chamber device, with either do a DO or VOO, will
Mhm.
you also adjust the lower rate? Would that be necessary to reduce perhaps the competition between the intrinsic and the device in case of depending on the indication for the pacemaker?
Yeah, no,
Uh,
yeah, that is absolutely a really good point, and you would typically. So if a patient's going in for surgery, for example, and even though they're dependent, we know they have PVCs, or they're not dependent, but they have intermittent pauses that are relatively frequent. So we decide to put them asynchronous. My recommendation would be to go VOO 80, VOO 85, 90 even. Maybe even 100 in some cases. And the reason being, as you said, to limit the instance of this competitive pacing. Anytime you're pacing into a T wave, you run the risk of being prorhythmic. So you could pace them into VT or to VF. So in those cases, that is why we would increase the heart rate. The idea being that we would beat out any kind of intrinsic activity, and we would beat out any kind of PVCs, because you're controlling the refractory period of the tissue. And by doing that, you limit the instance of that occurring. Does that make sense?
Yes, it does. Thank you.
Yeah, perfect. No, that was a great question. So VVI. So VVI is your next step of complexity, and it's still pretty straightforward. Elvis, do you want to take a shot at what this does?
Okay, VVI, we're pacing in the ventricle as well as tensing in the ventricle, and then responding to whatever goes on in the ventricle. There's a sense if there's an intrinsic beat, the device will be inhibited, won't deliver a pace. But if there's no intrinsic activity, it will count down and then deliver a pace.
Yep, that's exactly it. So exactly as Elvis said, we are pacing the ventricle, we are sensing in the ventricle, and then we're responding to those sensing with inhibition if an event is occurring. And the reason being is because we don't want to be prorhythmic, because we don't want to risk pacing the patient into refractory periods or into vulnerable periods that could kick off any kind of arrhythmia. So in this case right here, the device is set VVI, and judging from the timing, this is about 60 beats a minute or 1,000 milliseconds. So a ventricular event is sensed. This sets a clock of 1,000 milliseconds. So that means the device is going to go ahead and pace at, let's see, 300, 175, 60. So the device is probably going to pace around here. Let's see if I can count. 1, 2, 3, 4, 5. 1, 2, 3, 4. I cannot count today. The device was going to pace right here, where it planned to pace. However, an intrinsic event occurred. It doesn't know this at all. So what's happening in the atrium, the device has no clue at all. This is your P wave. However, it does have that lead in the ventricle. It senses on the ventricle a QRS complex. It resets the timer to 1,000 milliseconds, and it goes, now let me let Dr. Dafe in. 1,000 milliseconds from when the sensed event occurred. It waits. Nothing occurs in the ventricle, so it paces right here. That resets the timer. 1,000 milliseconds, it waits, nothing occurs, paces again, resets the timer. Something is sensed right here. So it says, oh, this is intrinsic. So it resets the timer 1,000 milliseconds from the sensed event and paces again. Once again, this is a very simplified form. This is one of the easiest ones to program, one of the easiest ones to understand what the device is doing. And yeah, this is what you'll see a lot of times in patients who are chronic AFib or patients who don't require a lot of pacing, they just need occasional support, you may just put in a single chamber device because it's the easiest thing to do. And it's a lot cheaper than adding an extra atrial lead, having a more complex device. So everybody on page here? Perfect. Next, we go to AOO. Very similar to...
Okay, sorry, please. If we go back to the previous slide, there's been this question about the T for the third category, that's the trigger. Usually, we don't see devices programmed that way, I guess. So, can you just throw some light to that T? How does it work?
Oh, the trigger pacing here?
Yes, yes.
Okay. So we can actually, I don't know if there's a slide on this later, but we'll go ahead and hit on it now. So what trigger does is, instead of causing inhibition, it causes pacing. So you may see a patient come in with VVT and you're like, what does this do? A reason for this is, instead of going VOO, for example, and inhibiting or pacing no matter what we can tell the device to do is, when it senses anything on the ventricular channel, it should also pace. So if this occurs right here, it will, let me let them in. There we go. It will go ahead, as soon as it senses, it will also give a pacing spike. Oops, a little off center here. But you may end up with something that kind of looks like a fusion right here, where we will be pacing into this intrinsic complex, not obviously in the vulnerable period here, because this is a big no-no. We don't want to do that. But instead trying to kind of fuse with the intrinsic. A couple of reasons you may do this, if they have a BiV and they have a lot of ectopy, but we're not atrially tracking, and we're, say, they have BiV with AFib with RVR or lots of PVCs with a biventricular pacemaker, one of the arguments you could make is, by having some electrical contribution to the intrinsic complex, you're getting at least a little bit more efficient pump to the QRS complex, a little more electrically efficiency. Because obviously, whenever we're programming a BiV, we're trying to get the most narrow QRS possible. And there's some degree of QRS narrowing when you pace into a complex. So that is one advantage of it. Another is, if you have a patient with occasional noise that's not that bad. Let me go back here, sorry. If you have a patient who has occasional noise, it may be advantageous to pace into, say this is noise here, it may just try to pace. Just in case, if this is noise, we go ahead and polarize the heart. And if it's not noise, then, and it's a true event, you just kind of fuse with it. So it's used as like a safety pace. And it's used as increasing your BiV pacing.
Looks like clean here. Sometimes you say they come
here, I'm going to go participants.
because
Okay, sorry, I had to take care of something. Okay, there we go. Elvis, did that answer your question?
Yes, it does. It does.
Perfect. You don't see VVT much. The only time
that's okay.
Yeah, the only
I'm
time
not using any words, so that's why I was wondering if it's still clinically relevant.
I think sometimes it just makes physicians feel better when they have a BiV, and generally you want to have greater than 86% pacing percentage, like BiV pacing percentage, to get any kind of like benefit. You know, generally you want greater than 90 to 95%. So if they have a lot of AFib with RVR, you see some physicians turn on VVT or DDT to try to at least get something where they feel like maybe they're assisting the patient, and the BiV isn't just essentially a paperweight while they have those high ventricular rates. So you won't see it much. If you ever see it and you ask and you're wondering what's going on, just, you know, reach out and we can talk through it. So AOO, we talked about VOO. AOO is the same thing. It's just in the atrium. We kind of talked on this last week, I believe, but we tend not to see atrial-based only devices. It was a thing in Europe for a while. The East Coast did it for a while. The advantage of this being you may reduce the instance, say if a patient only needs atrial support, you may reduce, okay, I'm trying to mute some people here. Okay, we're good. The only advantage of atrial-only device, maybe if they just have some degree of like sinus Brady or sick sinus syndrome, and they still have, they can get support without it worrying about like occlusion. It's a simpler device. It's cheaper. Down the road, you stick a bunch of leads in there and they're more likely to develop occlusion. You can get SVC syndrome, or it could be harder to extract if they get infection. So the argument can be made, it's cheaper and it's easier just to put it an atrial only lead. One big disadvantage of that, though, is you don't know what's going on with the ventricles at all. So if the patient develops some sort of AV nodal issues, we'd have no clue. And we could be pacing them all day long in the atrium and they could not be perfusing to their heart at all. Or perfusing to their body at all. So that is a big disadvantage of atrial only devices. You'll tend not to see most of these. You may see like a device that had ventricular lead problems and they don't need ventricular support. They had a dual chamber device. You may see them set AAI, which we'll get to later. But just for your own knowledge, if you come across this, AOO, as Elvis said earlier, you have a pacing in the atrium. You don't sense in the ventricle. You don't respond to anything or in the atrium either, sorry. You don't respond to anything because there's nothing there to respond to. So in here, we have our same thing, 1,000 millisecond timing, waits 1,000 milliseconds, paces again, waits 1,000 milliseconds, paces again. Patient has a atrial-only device. They have some sort of sinus bradycardia and they're going in for shoulder surgery or what have you. You may set them AOO just to make sure that they have that support. In this case, it doesn't matter whether or not anything occurs in the atrium. This is an intrinsic P wave. Device doesn't care. It's still going to pace at this time. AOO is much less risky than VOO because pacing into a vulnerable period in the atrium could put them into AFib. So sure, they could have AFib with RVR that could eventually degrade into something in the ventricle, but it's not like you're going to put them into VT or VF on accident with one pace. So just things to keep in mind. It's not as crucial to worry about atrial devices, atrial-only devices. AI here, that's going to be, pacing the atrium only, sensing in the atrium, and inhibiting only. You could technically have AAT. I assume, Elvis, I've never seen one, but it's technically doable. In this case, the device is sense an event in the atrium. It resets a timer, 1,000 milliseconds. Atrial event occurs, so it resets a timer, waits 1,000 milliseconds. No atrial event occurs, so it paces. You see depolarization here. And you can tell that we probably captured the atrium because you have this negative deflection on your P wave. Waits 1,000 milliseconds, paces again. Now, in this case, we probably have some degree of fusion. You can see this biphasicness to the P wave, which indicates that we probably contributed to it. So this would be like an example of atrial fusion. You tend not to even see anything at all. It would either just not capture or we would capture, but 1,000 milliseconds pace capture, waits, something occurs, it resets the timer from there, 1,000 milliseconds, something occurs. So one thing you may see with these kind of devices, AAI, VVI, a nurse on the floor, or whoever you're talking to could come in and say, hey, this device is set VVI 60, but the patient's going 80 beats a minute. How do we slow their heart rate down? Probably it's their intrinsic heart rate. We can't do anything about that. And I don't know how many times a day that I end up, well, not a day, but a month, I end up explaining to somebody on the floor that, I can't slow their heart rate down with a pacemaker. If the pacemaker is pacing too fast, that's something we need to address. But if it's their intrinsic, we don't have any control over that. And that's something you should probably control with medications or let the patient do their own thing. So, but yeah, that's AAI. Pretty straightforward. Here's kind of a weird one. And we kind of talked on this last week, but we'll go over it again. VDD. So you have ventricular-based pacing. You have sensing in both the atrium and the ventricle, and you have responding to that either with your ability to trigger, or you're going to have, it's essentially trigger or inhibit. So you can either, if something occurs in the ventricle, it will withhold the ventricular pace. If something occurs in the atrium, it could trigger the device to go ahead and track that, which is called atrial tracking, which is, once again, this is not a common form. You tend to see DDD as the manifestation of this. But if we have one of these leads here, sometimes you'll see a VDD lead, which actually has a ventricular, we have a little bipole here, and then it will actually have an atrial bipole as well, that has the ability to sense intrinsic atrial activity. So you cannot actually pace, you can't control the atrial activity, but you can follow what's going on in the atrium. Elvis, I'm going to pick on you again. Do you know a reason why we do this over having an atrial lead?
I'm not sure of the reason, but I believe it's likely they believe that the sinus node is fine. I'm not sure of the reason why, but I just believe perhaps they have that assumption that the sinus node is fine. There's no need of putting an atrial lead. Just go ahead with the single pass.
No, that's dead on. Exactly. So they have a functioning sinus. They don't have a degree of like chronotropic incompetence. Sorry, it ran away from me here. They have a functioning sinus. They don't have like chronotropic incompetence or sick sinus or anything like that, where we need to control what's happening in the atrium. We know their atrium's working fine. We're more worried about their AV node right here. So in order to kind of circumvent this broken AV junction, we have created a new pathway. And that's with our pace right here. So yeah, an advantage of one of those leads, and I don't use those, Abbott doesn't make those, but there are companies who do make them. The advantage of this is you don't have to worry about occlusion as much because you're only putting one lead. It's more simple because you're only having to put one lead and either stick once, or you don't have to use like we'll go through implant procedure some other date, but it's simpler to put it in. So you will see these occasionally, but probably not super common. I only know one physician who really uses them up here in Boston. Didn't really know anyone in St. Louis who used them at all, but this is something you may see. Another thing is you can actually program a device with two leads to VDD as well. The reason being for that would be, I don't know, there's really not a good reason to do that, but you might as well just do DDD in most cases. But yeah, it may occur. So if you ever come across it, that's what it's for.
Just a question there, AJ. I get given a load of leads and I've never ever seen a lead that does that. Is it got a special name, that lead, or is it a very special device you need to use if it can sense only in the atrium and pace in the ventricle?
So it won't need a special device because the lead actually, it looks like kind of like the DF1s or the old, where it kind of have this yoke where it bifurcates. So it actually has a ventricular plug and it has an atrial plug to the lead itself.
So it's got two plugs on it. So yeah.
Exactly.
Okay.
Yeah. I've only ever heard it called like a VDD lead. So I know it has a model number, but I don't know it. So
yeah,
so,
never seen it.
Yeah. So in the UK, sorry AJ, so Medtronic call it single pass lead. Single pass. It has been but it's not something that a lot of people tend to do because it has a habit of falling out, as in normally when it detects the P wave, it keeps like the P wave sensing keeps going down, the value keeps going down because it's dangling in the atrium. Whereas when you have your normal active fixation or passive fixation, that's actually in a fixed position. So single pass lead or VDD leads have a habit of displacing. So eventually they tend to program them to VVI, pacing, usually when somebody's really old, and a single like chamber pacing will be adequate enough for their circulation, cardiac output circulation to for them to get about and things. But yeah, Medtronic call a single pass lead. I've sent one to Dr. Daffy's got one actually. you should have one. Sorry, AJ, go on. Sorry.
No, that's great. So Dr. Dafe, if you haven't used it yet and you'd like to use it for a patient, I would think you'd want to maybe, for example, a small patient where you're more worried about either screwing in an active helix, or you're more worried about like forward pressure by putting in a passive fixed lead. You may consider this. I would assume that's what I would think clinically is the advantages is you don't have to worry about an atrial perf risk. And then other advantages is just, you know, if you're worried about them becoming occluded later in life or developing SVC syndrome, it's one less lead to take up any space. So I think it definitely has its advantages. I think that having just one electrode in the atrium is not ideal. If down the road they ever created one that had like, you know, you have your ventricular and then you had like a couple different atrial electrodes, kind of like what we see with an IS4, that'd be nice. But I think that honestly, we're seeing in the industry leaded devices going by the wayside within the next decade or two. And I think there's still going to be, you know, a future for them, but I think that companies are investing more in leadless technology. So we're going to see less innovation. I could be wrong. Don't get me wrong. I don't know what all the other companies are doing, but yeah, it does have its advantages. We just don't personally make one. So I really can't speak to them all because I haven't read the talk tracks on it. So.
Thank you very much, AJ. What you said, yeah, we will use it when the need arises.
Perfect. Yeah. So yeah, I would consult your Julius or your Medtronic representative for that one on that. So
I sent you an EKG. If you can look at it, the history is the patient had this intermittent AV block, a 12-degree heart block. So we put a dual chamber pacemaker for the patient. So after that, we sent him back to the referring cardiology, and the cardiologist saw the patient one day, and on a follow-up, and I asked him to do an EKG. So the EKG was forwarded to me. That was 2 days ago. Can you look at it and comment on it based on what we should do, what type of programming we should do for this patient? I also send it to Julius.
Is that so? It's not a very good ECG though, Dr. Dafe. Sorry, you can only see the chest leads. There are no, like, you can't see any limb leads and that. So, but I'll look at it properly.
Okay. So as we go on in the lecture, we can comment on it. Just zoom it. If you zoom it, it will be.
Yeah, but what I mean is, you should, for a 12-lead ECG, you should be able to see all the leads. I
agree with you.
Leads, but you can only see about 3 or 4. You know, so it's not really a good one.
I agree with you.
Yeah.
We can. Let me see if I can get this up here really quick. So looking at this one right now, I mean, from a 12-lead interpretation, yeah, it's not the most beneficial. But looking at it just from a pacer perspective, I mean, we're not really needing to pace. They have a steady PR. Here, why don't we do this really quick? 2 seconds here. Sorry to get sidetracked, but I think we have a little bit of time. So can everyone see this right here? Still?
Yes, we can see it.
Yeah. Okay. Sorry, I thought I ended the conversation for a second. Yeah, so I mean, this is the 12-lead you're talking about. EKG. Yeah, I mean, we have a PR interval. I don't know if I can zoom in any more than I already am, but let's see. Oh, we can. Okay, so we have a good PR interval. We don't have a long conduction timing. We have a narrow QRS. So there's really no indication for any kind of CRT or anything like that. So, I mean, from a pacing CRM perspective, there's no evidence that we need to be pacing most of the time. So these are the cases where we would have longer AV delays or allow this intrinsic conduction to come across. that would be the ideal for this candidate, is only pace when we need to pace. In general,
Yeah.
in the ventricle can contribute to heart failure. So pacing greater than, what is it, 40-50% of the time, that's actually an alert in many devices, because that you can toggle on and off. The reason being, let me bring this back just so I don't get too sidetracked here. The reason being, you can eventually contribute to their heart failure symptoms, and then we do end up having to put a CRT in them. So in this case, they have intermittent issues. They have their SA node, AV node, His bundle, and then conduction system to the ventricles. And this all seems to be functioning fine right now. This part seems to be functioning fine right now. So we do have, like you said, that you put a dual chamber device in, correct?
Yes, correct.
Okay, so say this is our IVC, SVC, IVC. We have our dual chamber device. I probably should have used different colors here. We are accurately sensing, based on that EKG, what's happening in the ventricle and what's happening in the atrium, and withholding that pacing. So when we talked about our dual chamber modes later, we can, we'll hit on this. But we talk about our dual chamber modes later. The device is seeing what's occurring in the atrium, so it's not pacing. It's seeing what's occurring in the ventricle, so it's not pacing. It's resetting its timer, and it's waiting to see if something occurs in the atrium. If it does, if nothing happens, it'll pace. And if nothing happens in the ventricle, it'll pace, which is what you're seeing displayed here. We'll go into deeper, details with that. But in general, what we're trying to do in these cases is, I would say you'd want to extend your ventricular pace as long as possible to let this intrinsic event occur. So if this conduction is going to occur, we give it as much time as possible, so we're not pacing this patient needlessly. Does that all make sense?
Yes, correct.
Perfect. So we'll keep moving, and then we get to DDD. I'll kind of talk into this in more detail if that works. Cool. So we have DOO here. So this is your first of your true dual chamber modes. Once again, pace in the ventricle. We don't do anything as far as sensing or responding to sensing in the ventricle or the atrium. We pace in both the ventricle and the atrium. So in this case, we're set, looks like 60 beats a minute. So our atrial timer is right here. Our ventricular timer is right here. I'll mark it negatively so we can kind of see the difference here. So our atrial timer starts, it waits 1,000 milliseconds for something to occur, and then it'll pace. At the same time, when the atrial timer starts, this starts what's called your AV delay, or the delay that the device waits to pace what's happening, or to pace in the ventricle based on either a sensed event in the atrium or a paced event in the atrium. So our paced AV delay looks like around 200 milliseconds. The device waits 200 milliseconds, nothing occurs, so it ventricular paces. This starts your ventricular timer over. Okay, so the ventricular timer goes, now once again, we're set DOO. So the device doesn't care that this atrial event occurs. It doesn't care that this ventricular event occurs. It just paces no matter what. This resets the atrial timer. It waits 1,000 milliseconds, paces again, resets the ventricular timer, waits 1,000 milliseconds, paces again. Same thing as VOO. DOO, you use an example, say the patient's going into surgery, or we know that the patient has issues with noise, and we're trying to bridge them to a gen change or revision or anything like that. It's just a way to kind of as a Band-Aid. So this is DOO. It's the most simple proper dual chamber mode. Does that make sense for everybody?
Yes, sir.
Perfect. DDI. Okay, so DDI is very similar to VVI.
Sorry, Mr. Adrian.
Yeah, go on.
For the DOO, would it be nice to as well shorten the AV interval, so as well reduce the competitive pacing, just to be on the safe side? Would that be nice?
I would agree with you on that. So as far as pacing into vulnerable periods, that's a really good point. Same as you said for VOO. DOO, I would typically go like at least, that's an 8, right? That kind of looks like an 8, at least 80 to maybe 100 beats a minute DOO. If you ever do MRIs, DOO is a common rate. They're going for surgery, anything like that. And as you said, it's to beat out any kind of intrinsic activity, whether it be conducted or whether it be PVCs. You can shorten AV delays. I will tell you, if you capture in the atrium, you're most likely not going to pace into a T wave. In this case, we pace into a T wave, but that wasn't an atrial capture issue. This was an issue of we're not going fast enough in general. So if our ventricular timing was set to be faster, we probably would have paced here no matter what, right? So I think that's a good point. You don't want to have like a 400 millisecond AV delay. Say you have a patient who is typically programmed, in Dr. Dafe's example about we're trying to let them conduct intrinsically. So they have like an AV delay of, instead of 200, we have an AV delay of like 350 milliseconds or something like that, right? That, if we had waited that long, could have resulted in us pacing longer into vulnerable periods of the tissue. So if they have very long AV delays, I would recommend shortening them. If they're 180, 150, something like that, it's not a huge deal. You can leave them shorter than that. But if they're above 200, I completely agree with you. Shorten them up a little bit. And those are the kind of things where, you know, I think it's important when you're dealing with pacemakers, you don't always have a template of what to do. It's more of understanding generally what the device is going to do, its actions, and then planning accordingly. So I think sometimes people who are inexperienced programming devices can put patients into dangerous situations because they're trying to fit this mold that doesn't necessarily fit the specific patient. So you have to tailor programming to the patient, to the circumstance, and to existing programming. So definitely agree with you here. It was 350, shorten the AV delay to at least 200. You can even go shorter, but that would be my recommendation. And then obviously go at a faster rate for DOO.
Thank you.
Yeah, thanks for the addition. That's really helpful. So DDI, we have dual chamber. We have the ability to sense in both chambers, atrium and ventricle, and we inhibit our actions based upon what is sensed. So that means if something occurs within one of those chambers, it will inhibit the pacing. So in this case, we have our same 60 beats a minute, nice and easy, 1000 milliseconds. The device paced in the atrium. We see a negative P wave, pretty good indicator that we probably captured there. It sets the timer, waits 1000 milliseconds, and then it's going to pace. If nothing occurs, same thing in the ventricle. It waits its programmed AV delay, which in this case is around 200 milliseconds. Nothing occurs in the ventricle, so it paces. So DDI is a ventricular-based timing mode, which means it doesn't really follow what the atrium is doing, but the atrial timing follows what the ventricle is doing. The reason this kind of matters is your A to A timing is not always going to be 1000 milliseconds. If a ventricular event comes earlier, your atrial timing is actually the V timing minus the AV delay. So in this case, your actual atrial timing is not based on this 1000 millisecond clock. It's actually based on the ventricular clock minus 200 milliseconds. So our ventricular paced event occurs, and it has then subtracted 200 milliseconds from what your ventricular based timing was, which is 1000 milliseconds. It subtracts 200. I'm left-handed and I'm using my right hand. So if this looks terrible, that's why. Subtracts 200. So your actual A to A timing is based on your V to A timing of 800 milliseconds after the ventricular event occurs. Why does this matter? Well, in this case, if an intrinsic event came across, let's see if we have one here. If an intrinsic event came across at 150 milliseconds instead of 200, then you would actually be shaving 50 milliseconds off of your atrial timing, right? Because this would be, instead of 1000 milliseconds, this would be 800 milliseconds after the ventricular event occurred. So if the ventricular event occurs here, it waits 800 milliseconds and then it atrial paces. And that means your total ventricular timing is your total atrial timing is 950 milliseconds. And everyone's like, why does this matter? I don't know, because you'll see it won't make as much sense if you don't know what's occurring. So just remember that DDI is a modified ventricular based timing. It's basically VVI adding atrial activity as well. Elvis, this is going to matter to you when you take the test, because they're going to ask you, why did this atrial pace occur earlier than 1000 milliseconds? Why did it occur at 950? When you take the IBHRE, that's why, because it's ventricular based timing. I know that is kind of weird and complicated. So if anyone has any questions, let me know. Okay, perfect. So
yeah, AJ.
Yes, sir.
AJ, sir. Yeah, you know, in Nigeria or in the sub-Saharan Africa, the commonest reason for pacing is AV block. That is the commonest.
Okay.
AV blocks are the commonest, and among the AV blocks, complete or third degree AV block is the commonest among them. So most time you will see a patient with AV block. Among, let's say if you have 20 patients for pacemaker, you will notice that 19 or 18 of them will have AV block. Then even among the 18 that will have AV block, there may among them, there may be also one or two among them that will have SA nodal disease. So in this case, when you put this together, what do you recommend? Because most of our age for pacing here usually towards the elderly and in the elderly. Most pacing here are done with people 60, 70, 80, 90, especially around 70. That is the clocking time for most of the patients. You can see some very few at 40, 50, but when you most of them, if you look at them, the age range is within that 60, 70, 70, something. So what do you recommend? What mode do you recommend most time to address? Because if you review the patient before the procedure, you will decide which pacing mode you are going to give based on the intrinsic activity of that patient. What you saw on the EKG and what you we think is the intrinsic activity, the native activity of that patient. So and now for people with AV block, because that is the commonest one we see here, what do you recommend commonly around here? Then also another set of people we also see, which is we see occasionally, are those with permanent AF and who had a slow ventricular response. And usually this group of people are more of 80 something years. Permanent AF that has a slow ventricular response from probably a complete heart block or Mobi type 2 or a high grade AV block. Okay. So what do you recommend in combining?
So you're getting ahead of me here. So yeah, no, so in general, and we'll go over this, and I realize how late it is all of a sudden, so I'll try to get to this a little quicker. But in general, you want to go for the most complex that you can get away with. So I think it puts a little more succinctly in the slides to follow. But whenever you're programming, you want to go with the best opportunity to have AV synchrony, and the best opportunity to kind of follow the intrinsic activity of their heart, so what their heart would do normally. So we want to reduce RV pacing if at all possible, because that can contribute to heart failure. However, if everyone's an AV block, we're going to have to pace the ventricle. right?
Yeah, yeah.
To increase atrial synchrony when possible, you want to increase atrial kick as well. So if we know the patient has complete heart block, we don't need to have long AV delays because we're going to pace them either way in the ventricle. We should not be waiting for their intrinsic event to occur. And this is kind of an issue with DDI, right? So DDI is paying attention to what's happening in both, and it's trying to maintain atrial synchrony as long as the rate is below the base rate. So if your base rate is 60, you're always going to have atrial synchrony, right? Nothing is occurring intrinsically. So we pace, we wait, we pace. So the atrial activity occurs, we wait the proper amount of time. If this was a heart, you end up having the atria squeeze, which then expands the heart and expands the ventricles, which allows it to have a better squeeze through the through the outflow tracts. So, and I'll go over this a little bit later, but in general, a DDI device is fine for patients who are below the base rate because you end up having optimal timing between the atria and the ventricle, allowing it to have that atrial kick, it expands the ventricle, it squeezes and pumps the blood out. You are allowing for intrinsic activity that's occurring in the ventricle if it does occur. And you're making sure that you're not dropping any kind of beats here at all. The problem with DDI is if the patient's rate increases, you end up having loss of atrial synchrony. So in this case here, our timer starts in the atrium. It's once again based off the ventricle, but it starts in the atrium. An atrial event occurs, and then it waits its AV delay and paces the ventricle. Starts again, an atrial event occurs, so it doesn't pace the atrium. It waits its AV delay and or your V-based timing in this case, right? So it's still waiting 1,000 milliseconds. So you're starting to see this prolongation of your PR interval. And we're seeing this occur here where it gets worse and worse until eventually their intrinsic activity comes across. So we're still waiting our 1,000 milliseconds. We don't care what the atrium is doing. We're not speeding up our ventricular timing. And in this patient right here, we're good, right? We're still making sure their heart is beating. But is this optimized for this specific patient? I would argue no. I would say this is not the proper programming for this patient because we're losing this AV synchrony, which means that the patient is not getting that atrial kick in the later events. And or the argument can be made we're not optimized because this patient may have intrinsic conduction. So we're RV pacing them greater than 50% of the time, which is also not ideal, right? We don't want to pace them all the time. We could pace them in heart failure in 40% of those patients. So I think that that's a really good point that you brought up, is that how do we decide what's best for this patient? And I think you kind of just have to have all of those factors in your head when you're optimizing a patient. Do they have intrinsic conduction? Am I trying to avoid RV pacing? Am I trying to maintain any kind of atrial synchrony? All those things should play a factor. If you're waiting 450 milliseconds for this intrinsic QRS to come across, if we're waiting all day and then it comes across, there is no more atrial kick at all. Like the atrium has squeezed and then the blood has just leaked its way back to the atrium through the valves. So that is an argument for why we don't need to wait all day to ventricular pace. Some people I've heard, and once again, you want to read the studies on it yourself, I'm not a doctor, but some I've worked with electrophysiologists will argue that if you're waiting 450 milliseconds, you're doing a disservice to your patient by waiting that long because they're losing that atrial synchrony. They're losing 30% of their output. So you kind of just have to weigh all those factors when you optimize a patient. So you'd asked about like what mode to choose. This is going to be your gold standard mode, your DDD mode. And this means you pace in the ventricle, you sense in the ventricle, and you respond to sensing a ventricle either by triggering or AV tracking or inhibiting with holding a pace because something occurred intrinsically. So in this DDD mode, you have an atrial event occurred. Now this is going to be an atrial-based timing. An atrial event occurs, it sets an AV delay, so it waits its 200 milliseconds, but before those 200 milliseconds come across, a ventricular event occurs. This resets the timer. It waits 1,000 milliseconds. An atrial event does not occur, so it apaces here. AP, if anyone was wondering. It waits 200 milliseconds for this to occur. A ventricular conduction does occur before the 200 millisecond timer comes out. So it resets the ventricular base timing. So we continue on here. It waits 1,000 milliseconds pace, waits 1,000 milliseconds, nothing occurs, it paces. So this is going to be your most advantageous for patients because when the atrium speeds up, we follow what the atrium is doing, right? So we maintain that atrial synchrony above the base rate of 60 BPM. That means if a patient is going 80 beats a minute in the atrium, we can then follow that and make sure we're pacing accordingly. Moreover, a lot of different companies have different algorithms. We have VIP in Abbott. They have MVP in Medtronic. I'm sure Boston has something, but I have no idea what it's called. And then Biotronic, we don't really see much of those. But these are different algorithms to add additional time when the patient is conducting. So it allows us to track what's happening in the atrium. It allows us to wait a little bit extra time for an intrinsic to come across and maintain this synchrony. But if nothing came across here, we would pace. There wouldn't be a T wave right here, obviously. This would be a new complex. And what that allows us to do is maintain our AV synchrony. It also allows us to regulate the heart rate based upon their metabolic needs of the patient. So this is your gold standard, and DDD is what you're typically going to see the most. But as you said, you have these patients with complete heart block. They're not going to be conducting much. So we are going to be tracking the atrium, but we'll probably keep our AV delays short if we know they're not going to be conducting. I'll keep it at 200 milliseconds. I'll keep it at 180 milliseconds. And then I'm just going to pace no matter what, because we know there's nothing intrinsic going to be breaking across, but we still want to maintain that atrial synchrony and also regulate the heart rate based upon demand. If the patient's exercising, their heart rate's going to go up, and we want the device to follow that. We don't want to go pace them at 60 beats a minute all the time. Does that make sense? Probably.
It's clear. Except somebody has a question. It's clear.
Okay, what's the question? I can't read the chat. Let's see if I can read it.
I said it's clear on my side. Elvis, you have a question?
Okay. So regards the intermittent AV block.
Yeah.
Would you think shortening the AV interval, would you think that would help it? Or would we want to just see how much of intrinsic activity would go in and then just back up the pulses?
Yeah, so intermittent AV block, I would set, so if I have an Abbott device, right, I would set VIP on, right, which in VIP, the way it does is it searches for intrinsic activity, and then it adds an extra programmable, but I usually do 200 milliseconds addition, right? So if their AV delay is 200 milliseconds already, VIP is adding 200 milliseconds to that to be 400. Now this searches, I usually program it every 30 seconds, right? So they have intermittent AV block. As you pointed out, most of the time, it's going to be pacing at 200 milliseconds, atrial pace, ventricular pace, atrial pace, ventricular pace. And then every 30 seconds or so, it's going to extend the AV delay to 400 milliseconds. And if nothing occurs, it'll ventricular pace again. And it'll do that 3 times. Once again, this is all programmable, but we'll do three times, 400 milliseconds. And then if nothing occurs, it always paces, and then it re-shortens the AV delay to be short again. So that means that most of the time you have this AV synchrony. You get that extra 20 to 30% of your cardiac output. And then if they are conducting, say an intrinsic event did occur right here, it would then leave the AV delays at 400 milliseconds. So that means at times when they are conducting, we're allowing them to break through. So we reduce our RV pacing. We're still following the atrium, and we're shortening AV delays the rest of the time when they aren't conducting. So it's kind of, you're getting the best of both worlds. We're reducing RV pacing percentage, but we're also reducing the amount of, or increasing the amount of atrial kick by allowing intrinsic conduction and not waiting too long. Does that make sense?
I've got a little question.
yes,
Just
yes.
is that MVP mode available on the sort of 3rd generation Medtronic Spheras, or is this like a brand new thing? So, because obviously in Nigeria mostly they've just got these Spheras and 3rd gens. Does Julius know, or anyone know?
Yeah.
It's
So
not available in
MVP,
Spera.
managed ventricular pacing, which is an AV node algorithm. So that it is on Azios. It is on Azios. It's also on Spheras actually. So yeah, it's quite on Medtronic. Yeah, so you can have So basically, all it means, I think I've spoken to Elvis about. So basically, all it is AAI to DDD. So yeah, it sort of paces the atrium if they're chronotropically incompetent, and then and just like AJ was saying, it will basically sense the AV node, just like VIP, and within a few cycles, it will sense the AV node extender, and if it finds any intrinsic, that's intrinsic, then you will just leave it alone and continue to support the atrium. So if the patient goes into complete heart block, if the AV node is stretched out with complete heart block, then it will just go into DDD mode, like AJ was saying. So Medtronic having AAI to DDD, Biotronic is DDD ADI. I was explaining to Elvis the other day, and Boston it's called Rhythm IQ. Rhythm IQ does what VIP does and MVP does. But Medtronic, the older ones do not have it. So Azure definitely has it. And Sphera also has AAI to DDD. So most of Medtronic nowadays actually have got that mode, AAI to DDD mode.
So Julius is not in Sphera.
No, you can have AAI to DDD, which does pretty much. Sorry,
it's
you can have you can have AAI to DDD, which does the same thing, intermittent thing. So
yes.
you can not manage ventricular pacing. If you're talking about manage ventricular pacing to trigger that, to put that on, AAI and DDD will be able to does exactly what MVP does. So
yes,
if somebody
right,
has,
but it's not on Spera.
In some of the older devices they don't have it. So Medtronic in some of the older devices that don't have the AAI to DDD mode switch, Medtronic has a thing called Search AV. It's very similar to Medtronic's VIP, Abbott's VIP. Sorry, so theirs is called Search AV. So any devices you guys are getting out in Africa that doesn't have the AAI DDD mode switch, you will have to look for something called Search AV, and it's very similar. You have a programmed AV delay, and then you add a Search AV of, say, like AJ said, 200 milliseconds. It will extend that out. If you get intrinsic rhythm rate, the AV delay will stay at 400 milliseconds. As soon as you pace at 400 milliseconds, the AV delay will shorten back into that programmed event. And then after a certain amount of cycles, it will then extend out again. And that process will just keep continuing and continuing throughout.
Yeah. Thanks, Jared.
Pleasure, guys.
Yeah.
Yes, the Spera we get in Nigeria has the Search AV feature, but does not have the MVP or the AI mode.
Yeah, but the point is, Elvis, you can AAI DDD does what you want. If it's an intermittent complete heart block, you can certainly put it that, and it will search the AV node over a few cycles, and if it goes into complete heart block, it will switch to DDD on its own. So all the Medtronics have got that. The new ones have that. But
the old one. The old ones which they sent to us here, Sentia and Sphera.
As I said, Sentia doesn't have that.
They don't have it. Even the Sphera they sent to us in Africa here, they don't have it. What will happen is that we will search it. That we see a picture with Sphera.
Dr. Duffy, the Spheras have got AI. Remember, we did that recently.
No, they don't. They don't have it, sir. They don't have AI mode. They don't have AI to DDD. They don't have AI to DDD. They don't have it separate, bro.
So which one did we do recently that was AI to DDD on a Sphera?
That's an Azure.
That is
No,
Azure, sir.
But have we not done a Sphera that has got that? No?
No, sir.
Spera only has a set.
You know, I've
AV
asked you
mode
the question
computer.
several times that why is it that we don't have this particular advantage in Sphera? The questions could not. I wasn't really satisfied with all the answer because they don't have it. So what we have in Sphera, I will post something. I think I have some images too. I posted something at a point in time to either when I was Dr. Joy wanted me to be part of co-founded mission. I posted something on that group at a point in time, telling us that look, this Sphera we have here has a lot of limitations.
Yeah, you did.
Yeah, I posted something of that nature at that time.
Yeah. Sorry, we
I will
don't
look for it and repost it.
Yeah, we don't have Spheras. We don't tend to do that here, actually, in my hospital anyway. So that's why. Sorry, man.
We just turn on the set AV future, and that's it.
Yeah. Let me see. Sorry, AJ, we're just distracted.
No, you're good. Medtronic is outside my wheelhouse, so I don't want to.
Yes.
I'm in
So
here.
AJ is good that Dr. Donnelly brought up this issue.
Yeah.
Because before now, it is now that we started seeing Azure, because Azure pacemakers are not sold in Nigeria. If I'm sure in Sub-Saharan Africa, they are not sold there. The pacemaker we get that is from Medtronic, which is the only pacing company that span this region, especially Nigeria, is Sentia and Sphera. These are the two devices we get. And this Sentia and Sphera, we don't have many of these software advantages that you have in Azure's and adapter and other new devices. We don't have that. So it is the opening up for Pace for Life and the trial that is going on that is making us to have this advantage of having all this Sphera. As Elvis, we implanted that last patient number 9. Elvis was shouting, that patient has an Azure that can treat AF. We don't have, if we are to use the old system, which we call new, they don't have all these advantages, which we now get being a part of the trial and being part of Pace for Life.
Yeah, no, that's a definite benefit. And I think that matters when you're choosing what device to use for what patient, right?
Yes.
I think that a lot of times, in the US, we have access to the ones we need. So it's less of a conscious decision before a procedure. But here, having these varied devices you have at your fingertips, I think you really need to think about what the patient indication is and what they need it for. And maybe don't give them a device that has all the benefits they're not going to use. And save that for the patient who will use it. Same thing with that VDD lead. If we know we're going to pace in the atrium, then we're going to put an atrial lead in. So yeah, I don't envy the added steps that you have for your decision-making process, but I think it's definitely something to keep in mind when you're selecting devices. In cases where you don't have VIP, where you don't have MVP or AI DDD, I think you just have to pay attention to see how much are we pacing the ventricle. If we know the patient conducts at 350 milliseconds, those are the cases where, you may allow for more time for them to conduct through and just set them at a 375 millisecond delay. If you're going all the way to 450, you got to weigh that against, are they getting that atrial kick? If we know the patient doesn't conduct until 500 milliseconds, then we're probably just going to set them at shorter AV delays so they get that atrial kick and at least have some benefit there. So just things to keep in mind. These algorithms make it easier to do more of a one-size-fits-all programming versus you have to be a little more conscious about it and maybe update it based upon the patient situation. So the patient could have normal, healthy conduction and degrade over the course of 10 years. And you may just extend that AV delay out when you see them to kind of compensate for that until it gets to the point where it's too long, and then just shorten it up and consider them as a CRT candidate if you start to see degradation of their heart failure symptoms or their cardiac output starts to go down. So, make sense?
Sure. Yes, it does. Thanks.
Cool. Really quick then, AAIR, VVIR, DDDR, these are just incorporating the sensor-driven rate. People use different sensors. There is blood temperature sensors, which you'll see on, I think, older Biotronic devices and the newer leadless devices that Abbott makes. There are piezoelectric sensors, which are like the pedometer sensors with traditional pacemakers that Abbott makes run off of. And they basically detect movement. And based upon that movement, they modulate the rate on that. There are different distinct advantages and disadvantages, and Elvis, I can go into detail with you about the advantages of both. With you all, you're probably going to mostly see the piezoelectric sensors or something like that. I believe that's what Medtronic uses as well. Correct me if I'm wrong, but in general, you're going to customize the sensor based upon patient needs. So, and if you ever need to optimize that, we can sit down and do a deeper talk on optimization of sensor based upon patients, whether or not they're very active or whether or not they need their heart rate to increase faster, slower. Those are things we can sit down and talk about at a later time. But the big things to remember here is that fourth setting in BG code is just sensor-driven rate. So if you have patients set like this and they're asking you on the floor, why is their heart rate going 90 and we're pacing? It's probably because the sensor detects movement or something along those lines. So, so mode selection, we've already talked about this quite a bit, but the big things we're looking at is what's the underlying rhythm for the patient? What's their overall cardiac condition? Are we trying to decrease the amount of ventricular pacing? Are we going to see disease progression? So do we think that they're going to have longer, more AV degradation? Do we need to leave a longer AV delay because we won't see this patient at follow-up? Things like that. Do they not have conduction at all? Do we need to have short AV delays? Are we maintaining our AV synchrony so we get that 30% of the atrial kick? And then obviously overall condition, life expectancy. So what device are we putting in? Do we need to put in a dual chamber device in a patient who has AFib? Probably not. It's probably, more expensive. It's more difficult. There's more risk involved in adding an extra lead. So if we know they're an AFib, VVI devices are generally fine. You see this a lot. So single chamber devices. So just considerations there. So why VVI? It's one lead, only one pacing spike to keep track of. It's really straightforward. It's pretty cheap to implant, but one of the big issues is loss of AV synchrony. So if they have a functional atrium, VVI device is probably not optimal unless it's one of those patients that they're just going to have an occasional drop in rate and we just need very, very intermittent pacing support. Then we could do a VVI device, but you do run the risk of having pacemaker syndrome where you actually have blood, where you're pacing the ventricle and you have blood backflowing into the atrium due to loss of atrial synchrony. So you'll end up with people feeling like pulsations in their throat, or they'll feel kind of like sick or not ideal. That's a reason why we may want to avoid putting a VVI device in someone with a healthy atrium. Dual chamber pacing. So you always have an atrial beat corresponding to a ventricular beat. You'll allow for that atrial kick, which is 20-30% of your cardiac output. Frank Starling law, Elvis, I'm sure you know this, but if not, study it because it'll come up. You want to mimic the healthy heart as much as possible. So everything we're trying to do is to act like a healthy human heart, down to CRT. We're trying to be as close as we can to the intrinsic conduction system because we haven't come up with a better system yet than what we naturally occur. And then obviously we'll avoid pacemaker syndrome. What are the drawbacks? It's harder to put in. There's an extra lead. There's more risk of occlusion. It's just, it's things to consider. And then obviously dual chamber modes, we're talking DDI, DDD. It is more complicated. So for the people who are going to support this in the field, it's something to keep in mind. It's not necessarily going to be the easiest thing to regulate. So we will get into dual chamber pacing on a different day because Lord knows I've already talked long enough for y'all and you probably need a break. But the idea with dual chamber pacing, just keep in mind there's 2 cycles, there's 2 channels we're having to deal with. and we'll go through all that. So are there any questions, I guess, before I hop off here?
Not really from my side. Maybe other people have questions, but I don't have yet. Elvis, do you have? Because it's good we ask all our questions so that we don't have issues when we encounter these devices.
I think what's important to understand is, especially Dr. Duffy there, is what he was saying is that given that most people in sub-Sahara, given that most of their indication for pacing is complete heart block, then really the most basic form of pacemaker is going to be enough for these patients. You're not going to need any of the fancy things. You're just really going to need something that is allowing you to going to program DDD at 50, 60 perhaps, and let them sit like that for 8 to 10 years based on battery life, obviously. But and as AJ said, maybe keep your higher end devices on the shelf for those patients that maybe present with intermittent heart blocks or 2-to-1 blocks who don't need pacing all the time. So then you can then use those AAI DDD modes. And so, yeah, maybe if that makes
sense.
Good.
Yes, sir. Thank you
and
very
obviously,
much.
And given the other population you face down there is your chronic AF patients with slow ventricular response. And again, just a very basic VVI pacemaker is suitable for these patients as well. Again, you don't need anything too fancy. So yeah.
Good.
Absolutely.
Then, sorry, this is a little digression. Mr. Gerard, do you, for a patient with biventricular heart failure that will require a biventricular pacing, and it has a chronic permanent AF, do you support the issue of not pacing the atrium? Because not all electrophysiology support that, but I know many centers in your side may be supporting that by taking out the atrial, putting a lead in the atrium. And if that happens, what do you do? Because these are patients who had heart failure. We had when I came for update sponsored by Pace for Life at Northampton General Hospital, I saw the things that are being done. They're very fantastic. So also, I also copy that into my practice, and that is also what I'm doing here. The one of our patients that we did for biventricular pacing, because he has a permanent AF, we didn't put anything in the ROA. So, and we kept, when we were to program, we noticed that if we program the base heart rate at 60, we are not getting enough. I remember AJ was the one that did that programming because St. Jude we used that day. So AJ that we called to do the programming. So we have to now move the base rate to, I think, around either 85 or 90, if I'm correct, AJ. Yes, before we were able to get a significant this thing. But my fear when I was agreeing with AJ that day, my fear was that this is a patient who has been in chronic heart failure for long period of time. Why am I giving this patient this high heart rate? So that was my fear. But all the same, I also I also agree with AJ that I'm going to step up the medication. But the problem of stepping up the medication is I need a blood pressure, a good blood pressure to do the stepping up of the medication. So these are some of the challenges that we face here, because you want to use medication to reduce the effect of the AF, but you don't, and most of the medications that you use, they're also going to reduce your blood pressure for you. Either you are using amiodarone or you are using a beta blocker, they will reduce the blood pressure for you. So you don't have So a blood pressure that is already at the borderline, you don't want to further TT too low so that you don't end up causing trouble for the patient. So these are some of the issues we face. So I don't know whether you have one or two suggestions to help us also to think through them.
Look, I think in my experience, I think someone with chronic atrial fibrillation, I think an A lead doesn't bring anything to the party. I think you're better off just going in there, putting in your LV lead, your RV lead, and capping off the atrial port. Because obviously, even if you did put an atrial lead in, the device isn't going to use it. All it's going to do is mode switch to DDI anyway, which would be then a non-tracking mode, or you end up going to program a VVI anyway. So really, your atrial lead's only going to give you really a bit of atrial information, which is going to tell you that they're in atrial fibrillation, which you already know anyway. So I don't think an atrial lead is worthwhile in these patients. So personally, we put in an RV and an LV lead and cap the atrial port with just a little pin port plug. The second thing is with, again, it depends on the level of device that you have. A lot of obviously the more modern devices these days have a thing called V-sense response, meaning that at the base rate of 60 or 70, if they're below that, then great, you'll be biventricular pace. But with AF, if you get a bit more fast conducted events, then by turning on ventricular sense response, it will trigger an LV pacing on top of the QRS, on top of the V sense. So it helps you kind of up your BiV trigger a little bit. It'll make your pacing percentage look a bit better, but there is still a lot of studies, a lot of research needs doing on how effective this truly is. My opinion is it's not hugely effective. It's good for making the numbers look good, but is V-sense response truly going to be advantageous as compared to BiV pacing? So there is a mode that, in VVI, as I said, then you can have this V-sense response turned on, which I would usually commonly do. The other option, I guess, is, and as you mentioned, is you could up-titrate their medication, up-titrate their beta blocker. But as you say, the consequence with that is then having to try and maintain a decent cardiac output and blood pressure. So that's always quite a challenging one. I'm not a doctor, so I can't really comment on with the what drugs you should or shouldn't give. But that's certainly, in practice that you see here is. And then on the fourth one for us, and again, I'm not sure if you have the luxury, but for some of these patients, this particular group of patients, is we would actually ablate the AV node. Now, I know you may not have that, that luxury.
Yes, so, we don't have that luxury here.
Yeah, okay, fine.
Very important. Very important.
So, so I think in this candidate of patients it's just a matter of programming VVI, turning on V-sense response, trying to up-titrate their beta blocker as much as you can. And seeing how you go with that.
Okay.
Because
thank you very much.
Yeah, I hope that helps, and please add more.
Yes, sir.
Yeah, those are great points, and I think that Elvis, you kind of mentioned like VVT. What is that? Jared, this V-sense response is essentially like a VVT mode, correct? Where you're just
essentially. Exactly.
So and kind of as we discussed, I don't know if you caught that part of it, but I agree with you. I think that some people like to feel good because it pads the numbers, but whether or not it's effective, who knows? But you probably have some degree of fusion, so you could argue it's helping. But whether or not it's helping worth the battery offset or anything like that. But yeah, no, I think that those are all really good points. What you could do, I don't know if you have access to echo, but you could assess, cardiac output under pacing at a higher rate versus under their intrinsic. And if their intrinsic is really that terrible, then I think you're better off pacing at a higher rate. But I'm not a physician either. And you need to take those conversations with physicians, which I'm happy to connect you with. But I think that you can use additional, clinical tools you may have in your toolbox to assess those things. And is higher rates of pacing better than allowing intrinsic conduction? It depends on how efficient their heart is. If they're a kind of weak indication for CRT, then pacing them all the time very fast may not necessarily be advantageous. So I would speak to one of our EPs that are happy to talk us through it.
Yeah, that would be good. So we want to hear and learn from the horse's mouth. So if you can talk to one of your EP, please, it would be great to receive the word of knowledge from him, sir.
Okay, sounds good. I'll run that by them and get their opinion on it. So
yes, sir.
All right, if there's not anything else to cover, I think that I've really overspoken here, and I know that Julius, you have some stuff to cover. Do you all want to take like a 5-minute break and then hop back into it?
Yes. So while we are proceeding for the break, is it possible you can update the slides and share what you think would be safe to share with us so that people can have it at their tab, revising with it?
Yeah, so I think I'm good to go ahead and share this. I have a larger presentation as well. I will get it to the group. I'll try to get it to the group either after the call or as soon as I can. But we'll get
Thank you, sir. Thank you, sir.
All right.
So 5 minutes break, then we'll take Dr. Julius' topic. So thank you very much. I'm grateful.
Perfect. Thank you, everybody.
Yeah, thanks,
Yes,
AJ. That was really
Thanks,
good.
AJ.
Thank
That
you.
was
AJ.
excellent. That was really, really
Thank
good.
Thank you.
And you could probably pause recording for the 5 minutes, maybe.
Oh, yeah, that's probably a good point, huh? Perfect. Julius, you have the helm. Let me pause the recording. Maybe. Oh, you have control, so you got to pause it. Looks like. Zoom recording. Okay, we're good.
All right. Thank you. Thank you.
And
For that.
no one on the recording has to know. We'll just act like delete this part.
Sorry.
Let's see.
Are you still trying to give me? All right.
Yep, you got it there. You're now host.
Okay. So share screen. Okay. Timing. Okay. Yeah, that's right. Okay. Okay. Can everyone see it? Yeah. Hello.
Yes, we can see it. Just put it
We got
on.
We
slideshow.
can see it. Just put it on
It's on.
PowerPoint.
Yeah, that's what I've done. Can you? Oh,
On slideshow.
yeah, it's on slideshow, right? Can you not see it? Can you? Is it coming out different or?
Yes,
We're
I think
seeing
so.
it,
What are
or
you
we're
guys
seeing a
seeing?
recording of your. We're seeing a recording of your screen. So perhaps you could stop recording and then put it on slideshow.
That was what AJ put record. Okay.
No, on your PowerPoint. The recording on your PowerPoint.
Oh, on that
what
one.
I'm doing.
Okay. So let me
Yeah.
come out of that. And then
Yes.
I think
Then,
is that okay?
yes. Then just click on the slideshow.
Yeah.
Is that better? Okay.
Yes. Okay.
Sorry.
Yeah, sure.
Sorry about that, guys. Sorry. Right. Okay. So what we have here is a 12-lead ECG. And it's absolutely essential when you're looking at an ECG, even before you look at the rhythm itself, that you look at the calibration settings on it. So the standard calibration setting should be, if you look at the top, here, it says 10 millimeters per millivolt and that. So it's either, when you look at an ECG, it's either you see this 10 millimeters per millivolt, or you see this calibration. That's your 10 millimeters. So that's 5 millimeters there. That's 5 small boxes, plus another 5 there. So that's 10 small boxes. And that's per millivolt calibration signal. So always look for that. When you look at an ECG, check to see if the calibration settings are standard. And the other thing you look at is your 25 millimeters per second as well. So that's known as the sweep speed. So the sweep speed should always be 25 millimeters per second. Elvis, we're speaking about, and AJ will support me on this, like when you look at your standard EP, EGMs, like they normally speed them up to about 100 millimeters per second, per second. So that means that it has to slow down so that you can actually see it. like that. So every 12 lead ECG that you look at should be 25 millimeters per second. Sometimes they might increase it to 50 if the patient has an AV&RT, for instance, so that you can actually see it properly. So it stretches it out so you can see it. But your standard calibration settings should always be 25 millimeters per second, and the amplitude should sweep speed, and the amplitude should always be 10 millimeters per millivolt. So if somebody has got like an LVH, left ventricular hypertrophy, where the voltage is really high, then they might maybe reduce it to half that, the voltage gain or the voltage amplitude, to 5 millimeters per millivolt. So always watch that before you even go to interpret the ECG. Otherwise, you could end up misdiagnosing the ECG, as it happened in the case that Dr. Duffy sent a couple of days ago. That the doctor completely misread it. So always check 25 millimeters per second, sweep speed, and 10 millimeters, or you can see at the bottom as well, 10 millimeters per millivolt voltage gain. The other thing to watch out for maybe is the frequency as well. It is often between, you can see 150 hertz, where you can actually see, as often said, 0.1 hertz or 0.05 or 0.5 hertz to 150 hertz. So that's the bandwidth, the frequency range in which the signal is collecting signal. Sometimes you might get people that might actually put in like a filter on, and we encourage you not to do that, to put a filter on if you can help it. Really good reason to put a patient has a Parkinson's disease when they've got tremors, when you might want to put a filter on, but otherwise do a good skin preparation, and then stretch out the frequency spread from 0.05 to 0.5 to 150 hertz, so you can get as much signal as possible from a collector mass signal. You don't want to cut off any of the important signals, right? So that's it there. So anybody got any questions here? Right, no, okay. So your 12 lead ECG. So AJ brought up that we should really look at how the ECG placements are with your 12 lead ECGs. The center bit here is your chest lead. Just to recap on what we said last week. So this is your chest leads, and that consists of 6 electrodes. So you've got in your 4th intercostal space to your right, a patient's right, is your V1, and then your 4th intercostal space to the left is your V2, and then halfway through the midline of your clavicle, in fact, sorry, between the midline of the clavicle, you've got your V4 on the 5th intercostal space, and your V3 is between your V2 and your V4. Your V5 is in the same horizontal plane as your V4, and it's a 5th intercostal space, and it's like at the anterior part of your axilla, of your armpit, at the front of the armpit, in the same horizontal plane as V4. So that's your V5. And your V6, again, is in your 5th intercostal space. In fact, it's in the same horizontal plane as your V4 and 5, and in the middle of the armpit, mid-axilla. And that, so it's always, that's the positions, the standard positions of the chest leads. And then your limb leads, you've got your right arm, obviously, you want to put it to the lower on your wrist, the right arm on your right, and the left arm, lower part of the arm on your wrist. And then you've got your neutral, could actually be anywhere on your body. Your left leg, obviously, is on the lower part of your leg, like by your ankle, if you want. But your right leg, your neutral one, could be anywhere. So that's your standard position for your 12 lead ECG, right? So yeah, so I wasn't really gonna have that. So let's speed on. Actually, hang on. Enter the waiting room. Oh, admit. Okay, somebody else is coming in. Right. Okay. So we're gonna go. Obviously, just a quick recap again. So in fact, I want to go to a different. Is that AJ? Is that okay? Like what I've just done? That yeah. Sorry, because I'm just trying to.
No, it's tough because people come in and no one can see you're clicking, so you just look like a crazy person who's just like clicking up here. I get you.
All right. Yeah. Thank you. Cheers. Thank you. Right. So yeah. So okay, just to go around really quickly. So you've got your limb leads, which lead 1 and AVL are your high lateral leads. So that normally covers your obviously high lateral LV wall. So your arteries like your first diagonal from your LAD, you know, if it's blocked, these are the important leads to look at. Your inferior leads as well, that's your right coronary artery. So inferior lead is lead 2, lead 3, and AVF. AVR is an interesting one that looks at the base of the heart. It is good for quickly diagnosing left main. It's very good for that left main. If you've got, everybody thinks a redundant lead, but if you've got things like tricyclic antidepressant overdose, AVR is a good one to look at. As well as your antiarrhythmic drugs as well, flecainide and so on, overdose, that's a really good lead to look at, because you look at the ratio between the S wave and the R wave. So that's, yeah, I mean, we can talk about that later on, but that AVR is a really good one to look at. It's not a redundant lead at all, because it looks at the base of the heart and it's always opposite to all the other leads. So V1 as well, you can see V1, obviously, that's good for the right ventricle. That's really good for the right ventricle. So if you get a right ventricular infarction, RV infarction, your V1 and V2 are good for that, as well as your inferior leads. We're going to see proper evidence of all this later on. So I'm just doing a quick recap. So your V3 and V4 really look at your septum. And your V5, V6 looks at the left ventricular wall. So you can see the outline at the bottom there, compared the ECG to basically the position of your heart, the anterior part and the posterior part. And the reason why, I think we go back here, when you have your ECG transition, when you got your V3 and your V4, if I can, hang on. Click on that. Yeah. So if you look at in B here, you see how from V1 you have your tiny R wave and you have a deep S wave, and that ratio changes as you move along the heart from the right to the left. When you get to maybe the apex from V3 to V4, you can see the transition of the S wave and the R wave is changing there, especially in V4. It's almost like it's a good transition there. So there's a normal transition when you're looking at your chest leads. So somebody whose heart's rotated, maybe more vertical, might look completely different to some maybe is rotated leftward, might have a delayed transition. You know, and so these are things to look out for. It might be a normal variant for the patient. And that's, but they should always get a transition normally between V3 and V4, where you get a transition. So the R wave, so that's really a reflection of the left ventricular wall, because that's the left ventricle, because that's the muscle mass of the heart. That's the muscle mass of the heart. So that's why, again, your R wave is actually coming up higher, and then it gradually, as you move towards your more lateral LV wall, the lateral LV wall, the V6 voltage, the QRS looks smaller because you're moving away from that. Is that okay? Is that, yeah?
Yes.
So thank you. So when you have LVH, when you have LVH and people are diagnosed, if you're diagnosing by Sokolow criteria, for instance, they will look at your by Sokolow criteria, by voltage criteria, they will look at your V5 and V6, your R wave or your QRS, the voltage of that. Then they add it to the S wave in V1. And if it's above 3.5 millivolts, then that counts as LVH by voltage criteria, by Sokolow criteria. So that's the transition of the people with left ventricular hypertrophy. Obviously, I've got thickened LV wall, so you see the R wave would be much taller, and that's a really good case in point, a good example. Right, okay. So we went over this, which I borrowed from Life in the Fast Lane as well, how the anatomical location for MI is. So you've got inferior leads, obviously lead 2, lead 3, AVF. So that's obviously looking at the inferior portion and the posterior portion of the myocardium and the right side of the myocardium. As you can see, there are 3 main arteries that supply blood to the heart: your right coronary artery, there, and your left main, which bifurcates or divides into 2, into your LAD and your circumflex, which is behind it. And your circumflex and your RCA fight for dominance. Your RCA, most people tend to be more dominant. So you've got about 70% of people tend to have more RCA dominance. So you might have your posterior descending artery, your PDA, which extends back all the way through the posterior portion. And that, so it fights for dominance. And you can usually tell if somebody has got posterior MI. Somebody has a posterior MI, you can actually tell if is it the RCA that's dominant, or is it the circumflex that's dominant based on the ST elevation. Whether there's more ST elevation in lead 1, or I'm sorry, lead 2 or lead 3. You can usually tell from that. Right, so in the future, we can also learn about how to calculate electrical axis, hexaaxial electrical system. So we can work that out. I'll teach you how to work that out. So, which is relevant for pacing, for CRT. This is really, really important that you can work out the axis of the heart. If you're LV pacing only, if you're biventricular pacing, and what the 12-lead ECG is gonna look like. You're looking at your V1 and your lead 1. Whether is it right bundle morphology, is it narrow complex, is it more right axis, and things like that. This is really, really relevant. Sometimes you might even use this when somebody has got heart failure by changing the LV RV pacing offset and you keep changing it, where -5 milliseconds, -10 milliseconds, -20 milliseconds, and see how the QRS narrows or changes into right bundle branch in V1, and lead 1 becomes more right axis, like more negative. So some people say some patients can respond better with this. Some doctors think this is completely rubbish. But I know St. Jude, I think it came from St. Jude actually. St. Jude actually brought this. Is that right, AJ? When you're doing 12-lead ECG pacing, LV, RV pacing to change the 12-lead to see if you can actually optimize biven pacing based on whether the QRS is narrowing. Yeah.
Yeah, so I'm not sure where who originated, but we do have an algorithm called QuickOpt, which is to kind of evaluate whether or not what the LV-RV offset timing should be. And we don't use actual surface EKGs. It uses EGMs and a surrogate of that, because one argument to all this is we don't know where the lead is placed half the time, right? Because it was placed 5 years ago, and now we're doing follow-up because they have heart failure symptoms. But what we're trying to do is get the most electrically narrow QRS. So we can use our surrogates in the EGM and then compare it to a surface 12-lead EKG and just try to optimize for the most narrow, electrically efficient QRS, I guess is the way I'd say it.
Brilliant. Excellent. Yeah, thanks, AJ. Yeah, cheers. Right. Okay. So let me go. So I'm just forwarding. You can see some lovely ECGs on the way there. So this is the one we looked at last time. This is what was sent. Like the patient ended up dying in Nigeria, which is what we started off with like a recent inferior MI, which was missed. So we've just gone over this, and we also went over this last week with the morphological or evolutionary changes with the acute MI, how from A, QRS looks normal. You've got a tiny Q wave, which is normal, and you've got a T wave, upright T wave. If you've got any questions, AJ, like please ask, because I can see your video. Yeah, excellent. Yes. Yeah. And so that's good. No, AJ, that's good. I like that because I can see. No, it's really good. It's really good. So within ROS, you can see STEMI there, ST elevation there. The QRS hasn't changed much. And then from days, you can see how the Q wave becomes a little bit more exaggerated. And the ST is still there, but it's morphing into a T wave inversion. And then from 1 week to 2 weeks or more, you can clearly see that the Q wave is there, is pronounced, and the QRS is obviously smaller because there's been an infarction, there's been like a scar formed, and you've got a more pronounced T wave there, T wave inversion there. And then once you're talking about after two weeks to months or even a year, Q wave remains. In most cases it might remain, and then your T wave goes back to normal. As it flips, it goes back to normal. And we spoke about LV aneurysm last week as well, how if it's an anterior MI, sometimes you can get, if it's an aneurysm, you can get Q waves already there, and with some slight ST elevation there, which some people might misdiagnose as MI, but that's clearly LV aneurysm. You can compare what it was before, and you can tell we spoke about that last week. So this is really a summary of the morphological changes that happen with MI, acute MI. So we went on to also look at some examples of it, 12-lead ECG, and this is what's this? Can anyone tell me? We went over this last time. Like, so I'm just wondering if anyone can remember what this is. What would you call this?
Anterior MI.
Yeah, anterior MI. But always tell the rhythm first. So if somebody asks you what is this rhythm, what would you say, Elvis? Because they will ask you that in IBHRE. If you don't say it, then if you just say anterior MI, that's wrong.
Yeah, it's a normal sinus rhythm. Excellent.
That's it, with anterior MI. That's it. That's fantastic. Yeah, so that's what I want you to say. So preparing you for the IBHRE now, because it's got, you can see your ST elevation there. It's more actually you're not wrong there. It's anteroseptal because it's from V1 to V4. But yeah, if you said anterior MI, yeah, that's fine. It's interchangeable. A lot of people, it doesn't matter. People use either. And that, so it's more anteroseptal because V4 to V5 is anteroseptal MI. And you can also see, like a slight changes there, reciprocal changes. It's not so good in this one. I remember when I was showing it, it wasn't so good, but you can clearly see in other ones that are coming. You should see a reciprocal change in your inferior leads. So this is an anterior MI. This is an anterior MI. And it's got a slight lateral extension. So it's anterolateral MI actually. And you can clearly see reciprocal changes in your inferior leads there. You can see that in lead 3 and also in lead 2. So much more in lead 3 and AVF actually. And the ST elevation isn't the level of ST elevation in anterolateral is not much in your level of reciprocal ST changes. And you always notice that isn't always equaled by that. So we went through this, an angiogram of an occluded. So anterior MI, we learned last week that is usually your LAD, your proximal LAD. It could be your mid LAD as well. Anterolateral involves your LAD and your circumflex. Usually, I think Dr. Daffy sent me an ECG during the week actually that had an anterolateral disease or occlusion on it. So that's an angiogram. You can clearly see proximal LAD there. It's not completely blocked. There's some perfusion there, reperfusion there, but you can see that right in the proximal area. You can see right in the proximal area that it probably was once occluded, but there's a reperfusion there going there. So the left main we were speaking about. So left main, you get ST depression and widespread ST depression, but you get ST elevation in your AVR and most of the time in your V1, so that's a left main occlusion. So you get widespread ST depression, as you can see in all this, from your V2, usually from V2 all the way on your chest leads to V6, and then you get your high lateral and you get your inferior leads, but you get ST elevation in your AVR and your V1. So this is your left main occlusion on that. So that's a big one. That's a big one. That's a big one. So yeah, that's fine. So also, you can also get this exactly, this particular pattern for your ECG. And this could also mean triple vessel disease as well. You can also get this for triple vessel disease as well. So there's an extensive disease in your coronary arteries with this left main. Is that a left main or triple vessel disease you can get with this one? Yeah, is that all right? Widespread ST depression, and you're looking at V1, usually ST elevation, and your AVR as well, ST elevation. Yeah, it's just remembering what it looks like. That's patterns. So left main. So we can see on your angiogram here, we can see the left main occluded here. Well, in fact, there's a reperfusion there, but you can see how this is the distal portion of the left main is really significantly narrowed there. So Dr. Daffy will be able to fix it and improve a stent in the right. So we spoke about Wellens syndrome as well. Wellens syndrome. So again, if you look at this V2 to V3, the two different types. So you can get, you're looking at V2 to V3. So you can get onset of chest pain. The first one is your biphasic T wave. You can see there, your biphasic T wave, slight ST elevation there, and it's morphing into your T wave inversion. So that's a biphasic T wave in V2 to V3. That's Wellens syndrome. And your the other type is your T wave inversion, complete T wave inversion in your V2 to V3. It's quite characteristic of your Wellens syndrome. So this is your LAD as well, block, and that's a look, watch out for that. And this is a really good example on a 12-lead ECG, what it looks like. You can see that biphasic T wave. It's like ST elevation there with your T wave inversion and the V2 with, and it extends into your V4. So Wellens syndrome, proximal LAD lesion. And the other one to watch out for is your De Winter's T wave. So that's named after De Winter. So you have like an upsloping ST with a hyperacute T wave, looks like hyperkalemia, with that sort of exaggerated T wave and large T wave there, but you've got an ST depression there, which is upsloping there into and is morphed into that. So this is the winter T wave. This is an emergent MI, proximal LAD occlusion. This is serious, but this is often misdiagnosed. AJ, you're scratching your head. You should just ask the question.
This is way outside my wheelhouse, so I'm
all right.
I'll take the questions for off the camera later.
Excellent. All right. Okay. Excellent. So De Winter's T wave is often missed by people, especially maybe registrars, A&E or whatever, or even cardiologists, registrars. It's an emergent MI, full blown MI. Maybe in a few hours you get full blown. So do not mistake that. That is coming. It's coming, and so you get this particular pattern with ST depression, upsloping ST depression, morphing with emerging with a hyperacute T wave, and you're looking at V2, V3, which might extend into V4 as well. So that's LAD, and you can already see reciprocal changes in inferior leads already. You can already see that happening. So sometimes it's really subtle, very, very subtle. You can't see it. So this is the posterior MI that we spoke about last week as well. So posterior MI, you're really looking at your so if you get ST elevation in inferior leads, but you're looking at your V1 to V3, and it might extend into V4. So you get ST depression in these chest leads, like V1 to V3. It might just be V2 to V3, and it might extend into V4. So these are ST depression, and what a lot of cardiologists do, because it's a posterior MI, you can do like a posterior ECG recording, like we spoke about, is in the same horizontal plane as your V4, V5, V6. You have V9, V8. I should really have a picture here, shouldn't I? Sorry, I should really have a picture here. But basically, all you do is, instead of doing that record, you can do that recording if you want. You can do V8, V9, V8, V7, right from in the same horizontal plane as a V4, V5, V6, where your scapula is at the end of it, your shoulder blade, and basically, put the electrodes there. Or you can turn the ECG upside down, which will show ST elevation in your V1 to V3 or V4. So people turn it upside down like that, you should see ST elevation. That's usually a posterior MI. You tend to have an inferior posterior MI, you get ST elevation in inferior leads as well. And then you might be able to diagnose whether it's, if you get ST elevation inferior, like as in this case, you get ST elevation in the lateral leads, the high lateral leads. Is it circumflex or is it right coronary artery dominance? So some of the books will say if you're getting lead 2, shows a higher ST elevation. So you've got ST elevation in the lateral leads. It's probably the dominance is probably the circumflex one there. Because if it's the right coronary, that's actually dominant, because it's stretching from there, and it's the PDA is going all the way stretching the back, is not likely to stretch enough to the high lateral LV wall or the ECG to actually go an ST elevation there. So it's more likely it's actually the right coronary dominance. It's more likely is a circumflex coming from a circumflex dominance, and that stretches to the right side as well. So you might get like an inferior ST elevation there. And Life in a Fast Lane really covers that really, really well. And that, so I would encourage you to go on that and have a look. Some books will say If lead 2 has a higher ST elevation and you don't have so this is a posterior ECG recording I was speaking about. I actually forgot I had it already. So you remove your V4 to V6, and then that becomes V7, V8, V9, and you can clearly see your ST elevation there. If you're doing a posterior recording on there, you can see your ST elevation there. So yeah,
is there a risk of false positive with V1, V2, V3 being negative, where you would need to do 7, 8, and 9? Or if you're negative in V1 through 3, is that a pretty strong indicator it's posterior?
Spot on, spot on. Yeah, so you don't need to do that. But some, yeah, you don't need to do that. Some I don't know, registrars might end up wanting to do that. And that's, so I mentioned that just in case somebody wants to do it, that it will be opposite, because it's looking at, because your V1 to V3 is looking at the front, the anterior part. So it's always going to be upside down. And if you want to, so the V7 to V9 are your posterior ECG recording. So that will really reflect head on what the ST, what the MI, where the MI is happening. So you get ST elevation in there, whereas your V3 to V1 to V3 is seeing it from behind it, like a mirror image of it. So you don't need to record that, actually. Hardly anybody does. So inferiolateral, again, inferiolateral, so you can see your ST elevation in your inferior leads, and then you've what is this called? Inferiolateral MI reciprocal chain. Well, it's not inferiolateral MI, it's just an inferior. You could even argue this is the inferior posterior MI. Sorry, this is headed wrongly. So it's an inferior posterior MI. Just pure, why? Because you've got ST depression in your V1 to V3. And if you put that upside down, you see that it will be slight ST depression there. And that, so this is more, so forget about that. This is an inferior posterior MI more than anything. Yeah. Is that all right? Is that, yeah. Yeah, okay. So there's always a reciprocal change when, you're looking at, there's always a reciprocal, but the fact that there is in your V1 to that to V3, you can clearly see ST depression. There's a small component of a posterior. So it's probably the right coronary artery that's really dominant, that's gone all the way to that stretches the back. Yeah.
I think that is what I explained that.
Yeah, that says that. You agree with that, Dr. Daffy?
The artery is dominant, so it goes beyond the cross of the heart.
Yes.
So that's, we explained that for us.
Yes, excellent. Right, let's move on. So yeah, that's the right coronary artery. As here, quite proximal. Right, okay. So we've a high. Is that okay? Yeah. So that's a high lateral STEMI. So as I said, high lateral STEMI, you're looking at your first diagonal branch coming from. Have I got a picture of that? No. So LAD, so you have your LAD, and you have, these are septal branches here. These are your septal branches of your LAD, and your diagonal will be coming from on the left side, stretching. Sometimes the diagonal, so most people have got either 2 or 3 branches, diagonal branches. So if it's high lateral, then it's usually like either your first diagonal or one of the obtuse marginal from your circumflex. So it will be coming from one of right here. And if you, the angiogram is done, if you're looking at the circumflex, that will be coming from the left side. So that covers a high lateral LV wall, supplies blood to the lateral LV wall. And your first diagonal also usually is a bigger one, also can supply blood to the high lateral LV wall. So So that's your high lateral STEMI. So you get ST elevation in lead 1. And we covered this last time, lead 1 and AVL. You can slide. So you get reciprocal changes in your inferior leads here. So lead 3, AVF, and the way you diagnose like MI doesn't mean that how you diagnose is if you get changes, whether T wave changes or ST changes in 2 contiguous leads. So it doesn't have to be 3 like inferior leads. If it's inferior MI, it doesn't have to be all 3 leads that have got ST elevation. So if 2 leads, you've got ST changes in 2 contiguous leads, then that is diagnostic of that. Yeah. So if you get Q waves in 2 contiguous leads, Q waves is more than a quarter or 25% of the QRS voltage, and you've got ST elevation, that's transmural inferior MI, if it's in inferior leads. So it's only 2 contiguous leads. It doesn't have to be all 3 leads. That is MI, whether it's acute MI or recent MI. So only 2 contiguous leads. So this is a high lateral lead. So this is old MI. This is old MI. You can clearly see there. So old anterior MI, and you can pronounce Q wave there with some probably like yeah. So it's still resolving actually. It's this could be LV aneurysm. This could be LV aneurysm. Deep Q waves with a resolving like ST wave. So anterior old anterior MI with maybe LV aneurysm component. Oh, there you go. So as you can see, like an aneurysm there on the right side of the LV, how it's actually protruding out. And when you do an LV angiogram with a pigtail special type of catheter, which has got a 9-hole, you inject the contrast dye, you can clearly see the accumulation of contrast dye in the aneurysmal portion of the left ventricle. And that's what the ECG looks like. So it's the old anterior MI with an L, which is obviously ended up being aneurysmal from that.
How old? Sorry, I don't do caths at all. So how old are we talking about here? When
So this anything more than 2 weeks, 2 weeks old, or anything more than 2 weeks is old. If it's more than 2 weeks and it's old. There is no reciprocal changes there. This is so you're looking at massive Q wave there. There's no reciprocal changes. If you're calling this like a recent MI, then there should be some kind of reciprocal changes in inferior leads, but there's nothing at all. And you've got deep Q waves, really deep Q waves like that, with slight ST elevation there. That's like definitely old MI on that. Yeah. Yeah.
Yeah.
AJ, I'm looking at you. Yeah.
No, once again, this is not my field of study, so it's very interesting. It'll slow down the group, but yeah, I'll look it up later. The electrical, why there's not the reciprocal change, I guess, is my question. But like, let's hit that later because I'm sure they all know this, and we don't need to.
So it's look all right. Yeah. It's looking at it from the opposite side.
Yeah. I'm just wondering like why acute versus chronic would have reciprocal versus the inverse of that. We'll talk.
All right. Okay. You made the morphological changes electrically. What's happening? Yeah. That's a very good question. Okay. there's a very, I don't think there's a lot of papers on it actually. That's a very, very good question. So when MI is happening, it normally happens, normal conduction is like endocardial to epicardial. Yeah. Like the transmural endocardial to epicardial. Obviously, when you have MI, the conduction is affected, and so that everything is so. For instance, why do you get like a T? Why is a T wave upright, and a Q wave is normal QRS is upright, and you've got T wave because depolarization and repolarization are different. Yeah. So, but when you look at the QRS, it's positive. And your T wave in most of the leads are positive as well. But so if it's depolarizing, and then it's repolarizing. So in fact, the normal ionic changes conduction, obviously, so the wavefront is from the endocardial to epicardial, and then when it's repolarizing, is really the direction of the net direction of the wavefront. So that's almost like reversing. But why is it positive? Why is it T wave positive and not negative if it's kind of almost reversing from depolarization? It's a really good question. Like, I think really good question. Nobody really knows that. And MI is also like that in terms of ionic conductance, what is actually really happening on the cellular level. Why is it like your ST, let's say it's largely to do with the calcium ionic change, calcium conductance, and it causes your ST elevation. Maybe we can actually do a presentation on this, because I'm not too, I don't know much. I can look into it. We can do a presentation on it as well and discuss it.
I'm down to look into it. I don't know if you want me to
excellent. Excellent. Yeah, we'll look into it. Excellent. Right. So this is an infralateral ischemia. Ischemia, obviously, ST depression. You can see there, you put somebody on an exercise treadmill. This is what you get, ST depression. Ischemia as opposed to infarction. Ischemia is a reduced flow of blood. Infarction, there's a blockage. There's no flow of blood to it, which is why in MI every second counts, because the blood supply is cut off, and things like that. So this is ischemic, infralateral ischemia. Probably if patient is obviously exercising, and that. So this is ischemia, ST depression. Single chamber ventricular pacing there, dual chamber. Do you want me to go through? I think that's me pretty much done with MI. I can go on. Should I? Are we? No, I think we've done enough, haven't we? I think we've done enough. Has anyone got questions of MI?
No question. Yes, we have tried today. Very great.
This is really good. I honestly, I appreciate it. It's a lot of the CAS stuff is outside of what my knowledge base, so it's good to have this exposure. But I don't know what group questions they may have. But
yeah, Elvis, have you got one?
No, I don't. I don't have any for now.
So, do you think you guys... Sorry?
I said I don't have any for now.
Okay. So, a really good one to look at, your Wellen syndrome and your De Winter's T wave. A lot of people, especially De Winter's T wave, actually do miss it because it doesn't have the ST elevation component. So that's a good one to remember, De Winter's T wave.
Explain that De Winter T wave again.
Okay, so that excellent. Thanks, Mr. Daffy. So really what you're looking at is your hyperacute T wave, particularly in your V1, V2, V3, and sometimes it extends into V4. So normally when you see widespread hyperacute T wave, you think hyperkalemia. You think hyperkalemia, but
right.
This is quite localized to V3, V2, V3, and you've got like a slight ST depression, which is upsloping into your T wave, hyperacute T wave, ST depression into that. So it's really characteristic of De Winter's T wave. That is an emergent MI that you need to act on it. Before it becomes full blown, like proximal LAD occlusion. Within hours. So a lot of people do miss that. A lot of people do.
Thank you.
That's a good
very good one.
And Wellen syndrome as well. Different types T wave. A lot of like African, Afro-Caribbean females might have like T-wave inversion from V1 to V3. So there are, again, AJ, there are different group variations as well, to make it complicated. I can actually do a presentation on that because it's really useful for benign early repolarization, differential diagnosis of that with MI, benign early repolarization, MI, and also pericarditis as well, pericarditis, and things like differential diagnosis. All of it involve like an ST elevation component. So I can do differential diagnosis on that. Like benign early repolarization, which they used to think that was benign. Let me see if I could go into life in a fast lane and bring, I don't know, have I got that any?
Honestly, you can present that to a lot of American doctors, because I think that the differential diagnosis between like racial background, like it makes a difference. And there's not a lot of training on it. A lot of the data and studies is based upon like white males. And then you try to apply that to other groups, and it's dangerous because it's not the same. People don't all.
Spot on, yeah. I mean, you might have like an ST elevation, but what to look out for is that reciprocal changes. If you don't have reciprocal changes with MI, you usually do. Usually do some kind of reciprocal changes, looking at opposing leads. You'd be able to say, so if you don't have that, even in the context of chest pain, then if it's an African, then suspect that it might not be that. And the ST elevation is also not, you look at it, it's not very convincing. So I'll show you what I mean by that. Life in the fast lane, like people to use their website for educational purposes. So I can go on it and use it. So so Elvis, IBHR. Oh, Elvis has got his hand up. Sorry, Elvis. Elvis, go for it. Speak. Yeah.
I just wanted to call your attention to your chat.
All right. Okay. Chat. Okay. Yeah. Thank you for that. So, please, gentle reminder. Admit. Please, I guess you might want to find it, please. Or, okay, yeah, I will, Elvis, I will. Let me just finish this really, really quickly. Yeah. My computer is almost frozen. Okay. Okay, so yeah, so it's really subtle. Like, can you guys see it? Can you guys see what I'm saying? Yeah. Oh, you can't. Oh, it's not.
You can just drag it over to the screen if you have two screens, maybe.
I'm going. Come on, this. I'm not sure what I'm doing here.
Did you open the PowerPoint inside?
Oh, and then drag it. Okay, yeah, I'm going.
Yeah, if you open the PowerPoint inside of Zoom, it can be harder, but.
So how do I get rid of that and let you see what I'm seeing on the Life in the Fast Lane online?
You can try minimizing this.
Minimizing this.
Yeah.
And hear that. Can you see it? No.
Nah.
Anyway, I'll do a presentation on it. So for benign early repolarization, you're looking at like characteristics, like there's a thing called a J point. A J point would be this bit here. It's a J point. Just after the QRS, if you see that narrow QRS there, so your J point would be where the cursor is at the moment. That's your J point. That marks the end of depolarization. and the onset of repolarization. That's your J point. So you might have like a notch. So J point is pronounced, for instance, in benign early repolarization or like hypothermia. You can get J point there. Yeah, so we can look at stuff like that, how to do differential diagnosis of early repolarization, and pericarditis and various sort of things. Also juvenile T-wave inversion also juveniles tend to have T-wave inversion from V1 to V3. So that's another differential diagnosis. And the T-wave has a particular characteristics, whether it's actually symmetrically inverted or is asymmetrically inverted. So all T-waves, whether it's upright or should have like if it's upright, should be asymmetrical. Yeah, okay. Should be asymmetrical. The T-wave should be. So for instance, the gradient. So the gradient initial portion. Let me see if I can get like
like the slew rate of the wave, almost like you're looking at
spot on.
Yeah,
spot on. Yeah. So the initial portion should be. If I can get classic one to show you. So the initial portion will have a lesser gradient than the terminal portion of the T wave, if you like. The upslope impact will be having that. So you look at things like components of the QRS or the ECG like that. I'm absolutely crazy for this, and we can spend ages. We can talk a lot about this ECG. So I did a presentation at the Scottish Cardiological Society on this, and I can do a presentation like on this for us as well, and so we can all build up our knowledge on this, because I'm crazy about ECG. But awesome. I do think the VT differential diagnosis of the VT and SVT with aberrancy, that's a really good one. That's a very useful one. Yeah. Right, I'm going to end it here.
Versus, I think that'll be a good one to compare SVT versus VT aberrancy on the EKG, as well as on EGMs as well, right? Because EGMs don't correlate, but you still have these similarities. So I love that. I have a good presentation on HV that we can probably pull some slides from too.
Okay.
If we do.
Brilliant. Yeah.
That would be great. So you and Julius will work it up for next week.
Well, oh man, Dr. Duffy, we do have other things going, Oh my word.
If you want to explain that to my wife, then yeah, that works for me.
Yeah,
I agree with you.
Yeah, we will see. We will see, because I've got a lot of things going on here, so we will see. I'll speak to AJ.
So what will happen, AJ and Julius? What will happen? So let me take cardioversion and defibrillation next week Sunday. Then upper Sunday you take it.
Okay. Excellent. Okay. Brilliant. That we're finished. So if I'll send you the slides, and if anyone has any questions, they can always text
people
me.
can post the question to you, and you will respond. You can respond to them privately or in the group. If something you want all of us to learn from, respond in the group. We will learn from it.
Okay.
Thank you very much.
Thanks, AJ. Thank you for your.
Thanks, AJ. Thanks, Elvis. Thanks, Dr. Darling. Thanks, Mr. Gerard. We are grateful.
Thanks, Gerard. Nice to see you on this.
Yeah, thanks, Dr. Sutoye. Everybody has kept to this point. We are
Thank you, everyone. It's been good.
Yeah.
Thank you, everyone.
Thank you, everyone.
Well done.
Yeah. Thank you, Joe. So, cardiothoracic surgeon, is that something you might come across, and Joe, like ECG?
Yeah, absolutely. Yeah, no, you're brilliant. Yeah, you are truly obsessed with the wonderful world of ECGs, but in a great way. So, yeah, that was really helpful. It was cool. I'm a pedant. I love detail. No, really well done. That was great. Very interesting. I think AJ liked it too.
Yeah, I wish I understood most of it, but I liked it. So.
Great. All right, great stuff. Well done. When are you doing it next, by the way?
2 weeks time. Is that right, AJ? 2 weeks?
Yeah, I think Dr. David said he wanted to do next week for his own. So I'm happy to hop on, and then 2 weeks time should be in town, down to do it.
Oh yeah, of course.
Are you going to create the code, AJ? Will you be all right to?
Yeah.
You can actually do you can post the same one. So one little tiny tip is if we don't want to constantly have to tap to invite people in, you can do it another way. You can do it a way which they just need a password and they can hop straight in, and it avoids you having to constantly click. So there are lots of ways to set it up.
Okay.
So